Is it visible now?
Yes, visible.
Okay, okay. So diabetes is a chronic metabolic disease, and one additional risk factor, which is often seen in diabetic patients, and that contributes to their elevated cardiovascular risk, is dyslipidemia. And this is not a kind of a normal dyslipidemia where a particular LDL has gone high or HDL has gone down. It is kind of quantitative changes as well as qualitative changes. So there are increased plasma triglyceride, postprandial hyperlipidemia, reduced HDL, and small dense LDL is higher. And in addition to qualitative and quantitative changes, there is an additional change which is called kinetic changes, which happens in diabetic dyslipidemia, and that is prolonged residence time of LDL in circulation. And as we all know that LDL, the level of LDL and the duration of LDL, both are very important in causing advanced atherosclerosis. So when we try to stratify patients and according to their cardiovascular risk factors and cardiovascular status, there are risk calculators where most of the more than 40 years male can utilize either a score system or a ASCVD risk calculator, or you can also use Framingham risk calculator. But there are some additional risks which puts a patient into a different category. So these are diabetes, CVD, established cardiovascular disease, CKD patients, familial hypercholesterolemia patients, and extremes of value of a particular risk factor, like someone who has a BP of 230 by 110. So straight away the patient goes into a very high risk category. Someone has a LDL of 210, straight away goes to a risk of very high risk criteria. So this is how we risk stratify. And when it comes to diabetes and then risks, stratification of diabetes and who are the patients who are going to require PCSK9 inhibitors. So let's see how we divide diabetes and the high risk and very high risk and moderate risk patients. So every patient of diabetes with target organ damage, straight away it goes to a very high risk criteria. And here the patient requires drugs which can bring down the LDL less than 55. And invariably the patient requires statin. And in addition to statin, we can, I think most of the times we need to use PCSK9 inhibitors. It is a different matter that we are using because of financial matter or not. Any diabetes patient who is more than 20 years of duration of 20 years of diabetes, they also fall in very high risk category. More than 10 years of diabetes patients, they are categorized in moderate risk, and then less than 10 years, they are categorized into mild risk patients. So those patients who are in moderate and high risk, especially high and very high risk, group of belongs to high and very high risk criteria, they require PCSK9 inhibitor therapy. So once again, when we talk about treatment of diabetic dyslipidemia, the primary goal is to lower plasma LDL cholesterol levels. A secondary goal is to the reduction of other non-HDL cholesterols like ApoB and small dense LDL and lipoprotein little a. And finally, our goal is the clinical excellence, the patient's longevity. So till now, there are gaps in treatment. Significant cardiovascular risk often remains in type 2 diabetes patients despite maximal statin therapy. And in order of achieving less than 70, less than 55, it's a humongous task and we require more than statin. And this is how we can address this residual risk by using PCSK9 inhibitors. And FDA has already approved the adjunct therapy to maximally tolerated statins to further lower LDL cholesterol levels to reach in target level. So what is bonhomie between PCSK9 and diabetes? This is very important and very funny to know about. PCSK9's impact on LDL cholesterol metabolism. There are several observations suggest a direct correlation between PCSK9, diabetes, and diabetic dyslipidemia. Many studies have found increased plasma PCSK9 levels in type 1 or type 2 diabetes patients. In vitro studies and in vivo studies in mice and some human trials have proposed that insulin is a positive regulator of hepatic PCSK9 expression. when the we are fasting, it increases the you know uh, like it lowers circulating insulin levels and also strongly reduces PCSK9. So there is a kind of direct correlation. And PCSK9 levels were also positively associated with insulin dose in type 1 diabetes patients. And this PCSK9 levels in type 2 diabetes might be a consequence of the selective hepatic insulin resistance that is characteristic of type 2 diabetes patients. So there is a in support the finding that plasma PCSK9 levels were positively associated with hepatic insulin resistance in healthy volunteers who are fed on a high fructose diet. So it can provoke hypertriglyceridemia and hepatic insulin resistance. And lastly, it should also be noted that an uncontrolled type 1 or type 2 diabetes can disrupt the relationship between plasma PCSK9 and LDL cholesterol metabolism. So it is not that the bonhomie remains there forever. If there is an uncontrolled type 2 diabetes or type 1 diabetes, it can disrupt this friendship as well. So what about PCSK9 inhibitors in diabetic patients? So we have discussed about who are the patients of diabetes where PCSK9 inhibitors can be given, the risk category, the high risk and very high risk. So when we talk about PCSK9 inhibitors, we have got 2 or 3 very large trials like Proficio, Odyssey, and then FOURIER. And we are not going to talk in detail about FOURIER. FOURIER trial, everyone knows it in this platform, that there was around 59% reduction in LDL on top of statin, and cardiovascular outcomes were also reduced. This was patients with diabetes at baseline and patients without diabetes at baseline. There was not much of difference, but here lies the difference. There was a kind of NNT of 37 patients as compared to NNT of 62 in non-diabetic patients. So without diabetes, we have to treat 62 patients to get the benefit in terms of CV death, MI, stroke, hospital for unstable angina, or coronary revascularization. But we need to treat only 37 patients with diabetes, with statin plus PCSK9 inhibitors to get the benefit. Effect of PCSK9 inhibitor Dilip on other lipid parameters in diabetes or patients without diabetes, there is not much of difference. The Odyssey trial also reflected the same findings. It was a post-ACS patients. So we all are aware of the fact that maximum mortality in CAD patients, they happen because of acute coronary syndrome. And it might be useful for everyone in this CME to know about the fact that in India and in Western countries, the kind of ACS is different. In India, we see a lot of ST elevation patients. Majority of the patients are driven by ST elevation, MI patients. But in Western countries and US, we see a lot of non-ST-MI patients, the bulk which contributes to acute coronary syndrome patients. So definitely our patients are sicker and our patients require immediate management, because in ST elevation, if you don't, use our all weapons early, then we are going to lose the myocardium and eventually the patient as well. So this was a trial with on post-ACS patients between 1 to 12 months. And they also showed the similar benefit of around 50 to 52% reduction in LDL cholesterol. The efficacy of the primary efficacy endpoints were, reduced. The absolute risk reduction was 1.6% with p-value of 0.0003. All-cause death was also numerically less with a p of 0.02 and absolute risk reduction of 0.6%. And in diabetes patients and in non-diabetes patients, there was not much of difference, but there was a greater absolute risk reduction in diabetic patients. So similar findings we found that in Odyssey as well as in FOURIER trial, diabetic patients had more absolute risk reduction and NNT was lesser. So definitely those patients of prolonged diabetes, patients with target organ damage, they qualify for PCSK9 inhibitors and in order to achieve the target LDL cholesterol. Odyssey diabetes dyslipidemia trial, again, This also showed a subgroup analysis showed that there is also a qualitative improvement in lipid profile. The LDL particle number and LDL particle size were reduced in patients treated with Dilip Kumar, and small dense LDL were lesser. Various trials show similar efficacy of PCSK9. Huge list of trials shows that the difference in LDL was really highly significant, so as the clinical endpoints. Now coming to qualitative change in the lipid profile with PCSK9 inhibitors in diabetes. There are another trial called Banting trial. It showed that in statin-treated individuals with type 2 diabetes and hypercholesterolemia or mixed dyslipidemia, evolocumab significantly reduced LDL cholesterol and non-HDL cholesterol. And there was favorable changes in postprandial levels of chylomicrons, VLDL, cholesterol, and LDL. So it's not only LDL is coming down, chylomicrons, VLDL, small dense LDL, and lipoprotein little a is also, are affected in a positive manner. This is the reduction of ApoB by PCSK9, and again a trial shows that the postprandial triglyceride level is also less when PCSK9 inhibitors are given. So in essence, quantitative as well as qualitative changes are happening, and so as the clinical findings, and that is why the NNT is less in diabetic patients who are being given PCSK9 inhibitors. So these results are in terms of reduction: plasma triglyceride 21%, VLDL 15%, ApoB 17%, ApoC3 14%, remnant cholesterol 29%, and LDL, of course, in this trial 78%. So nothing, more we expect from the studies to give a documentation and evidence that in diabetes patients, especially who belongs to high and very high risk criteria on statins, if we treat these patients with PCSK9 inhibitors, we are going to better the results, not only in terms of quantitative findings, also in qualitative aspect of lipid constituents. Safety is already proven, and this is the beauty of this part of this particular group of molecule. It is as safe as that placebo, and that's why I'm not going in details regarding glycemic parameters and the new onset diabetes. They all have been shown that there is nothing that sort of complication and findings which is happening with PCSK9 inhibitors. So these are as safe as water and placebo. Finally, cost effectiveness, which is always talked about, and this is the biggest stumbling block in using PCSK9 inhibitors. But definitely the rationale is there to use this, as advantages are huge, and disadvantages of less costly medicines are also there, because when we talk about niacin, when we talk about subric acid derivatives, when we talk about additional medicines like HTMI, we don't have much of clinical evidence, and possible adverse effect on glycemic control remains to be verified in longer clinical trials. Finally, a word about PCSK9 in ACS. So this is the last trial which I'm discussing, and that is very important, because we as a cardiologist, we as a clinician, we as a physician, we are most scared about acute coronary syndrome patients, because these are the patients where we are going to lose the life of patients. The stable angina patients, they remain do well. We have ample of time to correct the patient's physiology and patient symptoms. But acute coronary syndrome patients, they are at verge of this way or that way. And diabetes, a potential residual risk factor in ACS. So these patients have got higher tendency of non-culprit lesion, plaque rupture, and followed by adverse events. But with evolocumab, if we use, then we can change the quality of lipid profile, and probably the plaque stabilization is there. So among patients following ACS on treatment, levels of small dense LDL cholesterol, remnant lipoprotein cholesterol, triglyceride contribute to rapid progression of non-culprit plaques. That is leading to recurrent cardiovascular events and eventually death. And evolocumab acts there. And this is not by the just by seeing the levels of different lipid molecules, but this is proven by an MRI-based study that when we classify into LDL, VLDL, small, medium, large particles, it was found that significant larger reduction in small LDL and VLDL happened with evolocumab, and size of the LDL particles before and after medication in the evolocumab group showed an increase of 3.6% in size of lipoproteins after treatment with evolocumab. So once again, it re-emphasizes the need of aggressive management, especially in acute coronary syndrome patients. So these are the MRI-based study, and results shows that ApoB, LDL cholesterol, the LDL particle size, the lipoprotein little a, they all are reversed in a positive manner. And when given for 8 weeks, it could significantly improve the plasma lipid profile in ACS patients with poor lipid control, and maybe can reduce the recurrent events and finally save patient lives. So this is my final slide. This is what the topic was given to me: diabetes, PCSK9 inhibitors, how to stratify. So this is the way we stratify. We have already talked about. So very high risk patients, those patients of diabetes with target organ damage, or more than 3 major risk factors, or early onset of type 1 diabetes of long duration, more than 20 years, they need to be given PCSK9 inhibitors in order to bring down the LDL less than 55. And sometimes if the patient has a recurrent event, this level goes to less than 45 or 40. So none of the, there is no trial which has shown that below there is a level below which LDL reduction is going to cause us harm. So probably we are moving towards LDL elimination from LDL reduction. The high risk category of patients, once again re-emphasizing diabetes patients without target organ damage, but duration is more than 10 years, and other additional risk factors. In order to bring down LDL less than 70, again, we may require PCSK9 inhibitors. So this is how we stratify, this is how we classify diabetic patients, and the evidence of evolocumab, or in general, PCSK9 inhibitors in diabetes acts. Thank you so much for your kind attention.